Hey Liam, here's a quick thought experiment. If your clinical trial finds no treatment effect, is it because the treatment doesn't work? Or because you didn't enroll enough people to detect it? That's the classic sample size trap, and it's what we'll be discussing today.
Hello and welcome, folks. I'm here with my co-host, Angela. Today we're talking about sample size and power calculations in pragmatic clinical trials, all to answer the burning question, how many participants do I really need for my trial? Before we jump to that answer, let's start with the need to engage a qualified statistician early.
As you'll see as we go through the module, there are a lot of considerations in estimating your trial's sample size. So if there's one piece of advice we hope you take from this module, it's to engage a biostatistician in your trial from the get-go. A biostatistician's role as a member of the team can help shape your study from the beginning, ensuring your design choices align with your research questions. When things get complex, like multiple outcomes or clustered data, they guide you through those decisions. If standard formulas fall short, they can run simulations to test what really works. And finally, they make sure every assumption and calculation is clearly documented to meet ethical, regulatory, and reporting standards. It's expertise that safeguards both your science and your credibility.
There are three big reasons why sample size matters. First, if you enroll too few participants, your study might be underpowered, meaning it could miss a real effect that actually exists. Second, enrolling far more participants than needed can be wasteful. Trials with way too many people use up time, money, and resources that could be spent elsewhere. Practically speaking, more participants mean higher costs and longer trial duration. Third, ethics come into play. It's unethical to run a trial that's knowingly underpowered, because why would we expose people to an intervention if we can't answer the question? And it is similarly unethical to expose more people than necessary to an intervention that might have no benefit or even potential harm. In short, we want a sample size that's just right, not too small and not too large, to confidently answer our research question. Every sample size calculation boils down to a few key components, or inputs. Let's break them down one by one.
The first key component of any sample size calculation is setting your risk tolerance, meaning setting the significance level and target statistical power. The significance level, often called alpha, represents the risk of declaring a treatment effect when there really isn't one. By convention, alpha is set at 0.05, which limits the false alarm probability to 5%. Statistical power is tied to the concept of significance level. Statistical power represents the probability of detecting a true treatment effect when one actually exists. By convention, trials aim for 80% or 90% power, meaning there's only a 10 to 20% chance of missing a real effect.
So, here is a question. Why don't we just set statistical power to 100%?
Wouldn't that be ideal? But a trial would require an infinitely large sample size to achieve 100% statistical power. In essence, it comes down to striking a balance between confidence in answering our research question and the feasibility of conducting the clinical trial.
So moving on, the third component is setting the expected effect size, which is essentially the clinically important difference you want to detect. Sometimes we call it the target difference, or delta. For example, if we're testing a new blood pressure drug, we might say, we want to detect at least a 5 millimeters of mercury drop in systolic blood pressure compared to control, because anything smaller might not be clinically worthwhile. Always ask yourself, what difference would make me or partners say this intervention is worth it? Whatever the answer is, that is your target effect size.
The fourth component of sample size estimation considers the outcome type and its variability. This means how much natural scatter or variability there is in the outcome measure. For a continuous outcome, variability is usually quantified by the standard deviation. For a binary outcome, variability depends on the proportion. The same principle applies to other outcome types too. For count outcomes, like the number of infections or hospitalizations, sample size depends on the expected event rate. The more variable those counts, the larger your study needs to be. For ordinal outcomes, such as pain scales or disease severity, it's about how the responses are distributed across categories, and how much of a shift you expect between groups.
Then we have time to event outcomes, like time to recovery or rehospitalization. Here, power depends on the number of observed events, not just the number of participants. And for rate outcomes, such as infection rates per patient year, both the expected rate and follow-up duration drive variability. In short, more variability means you'll need more participants to confidently detect a difference.
Those are the 4 core ingredients for any basic sample size calculation: alpha, desired power, effect size, and outcome variability. Once we decide on those, we feed them into the appropriate formula, or software, to solve for n, the number of participants needed. The exact formula differs by study design and outcome type, but the logic is always about balancing those same components.
As part of this module's materials, we've included a link in the description of this video to an interactive sample size formula tool that can help with choosing the right formula and calculating sample size for a 2-arm parallel group individual or cluster randomized trial. Users select their study design and outcome type, enter parameters, and instantly see the appropriate formula, computed sample size, and sensitivity plots. As an example for an individual level trial with a binary outcome, we use the default values of alpha equal to 0.05, power equal to 0.80, control event rate equal to 0.50, and intervention event rate 0.60. The tool then calculates the required number of participants per group and lets you visualize how sample size changes as effect size or power varies.
Planning for attrition is another practical point when estimating sample size. No study retains 100% of participants through to the final analysis. People move away, withdraw, or get lost to follow-up. When we plan for attrition, we typically assume that participants lost are missing completely at random, so their absence doesn't bias results but only reduces power. If we anticipate, for example, a 10% dropout rate, we'd increase our enrollment target by roughly 10%. For example, if our base sample size required 388 participants per arm, we'd aim for around 431 per arm to maintain 80% power despite the expected losses.
So far, we've been talking about trials where individuals are randomized. Now let's switch gears. What if your trial isn't randomizing individual people, but entire groups? Many pragmatic trials randomize at the group or cluster level, for example, by clinic, hospital, school, or community. Cluster designs are powerful and often necessary for pragmatic studies, but they introduce extra wrinkles in sample size calculation, as Angela will explain.
Yeah, that's right. With cluster trials, we need to add a few extra ingredients to our sample size recipe. Beyond the standard inputs like alpha, power, and effect size, we also need to specify the number of clusters or their average size, the intra-cluster correlation coefficient, ICC, and, if cluster sizes vary a lot, the coefficient of variation. These details ensure the design accounts for the similarities among participants within the same cluster. Once those are defined, we apply the design effect to inflate the sample size appropriately, aim to maximize the number of clusters, and always plan for potential attrition at both the cluster and participant level. Liam, can you go into what the ICC is and why it matters so much in sample size estimation?
Yes, absolutely. So, in a cluster randomized trial, participants within the same cluster tend to be more alike than participants in other clusters, maybe because they share the same environment, care providers, or other contextual factors that make their outcomes correlated. In theory, the ICC can range from -1 to 1, though in most health research trials, it typically falls between 0.01 and 0.1. A value of 0 means no clustering effect, while a value of 1 means everyone in a cluster has identical outcomes. If individuals within the same cluster respond similarly, we're not getting as much independent information from each additional person in that cluster. In other words, 100 patients all from one cluster do not provide as robust evidence as 100 patients from 10 different clusters. The ones in a single cluster might all rise and fall together. So, to achieve the same statistical power, a cluster randomized trial generally needs a larger total sample size than an individually randomized trial. We account for this loss of information by using an inflation factor in our sample size calculations, often called the design effect.
The design effect tells us how much larger our sample needs to be compared to an individual level trial. When cluster sizes are roughly equal, the formula is 1 plus the average cluster size minus 1, multiplied by the ICC. But if cluster sizes vary a lot, we correct for that variability using the coefficient of variation, or CV, in the formula. In both cases, M represents the average number of individuals per cluster. The higher the ICC, or the more variable the cluster sizes, the greater the design effect, and the larger your required sample will be.
Let's illustrate with a graphic of how the ICC and average cluster size impact the design effect. From the figure, we see the design effect grows as both the ICC and the average cluster size increase. Even modest ICCs can greatly inflate your required sample when clusters are large. For instance, with only 10 participants per cluster and an ICC of 0.01, the design effect is about 1.1, barely any inflation. But with 100 participants per cluster and that same ICC, the design effect nearly doubles. As ICC rises to 0.05 or 0.10, the inflation becomes dramatic. The takeaway? The larger your clusters, the bigger the hit you take from any non-zero ICC.
What really drives your power in a cluster trial is often the number of clusters, not just the total number of individuals. Adding more participants to an existing cluster helps a little, but with diminishing returns. In fact, if ICC were very high, approaching 1, meaning everyone in a cluster behaves the same, adding people within one cluster would hardly help at all. So, with that in mind, when we only have a few clusters, our effective sample size for inference becomes quite limited, even if we're analyzing data at the individual level. For example, having just 5 clusters per arm gives us only about 10 independent groups contributing information, which could be too few for precise estimation. In these situations, the large sample assumptions behind many statistical methods can break down, leading to unstable standard errors and unreliable p-values.
Now, whether we're doing an individual or cluster-level trial, where do we get the values for our sample size input parameters? Setting alpha equal to 0.05 and statistical power equal to 0.80 is straightforward, since those are standard choices. But choosing an expected effect size or estimating the outcome variability requires some investigation and judgment. It is as much of an art as a science. Whenever possible, we use data from published literature, estimate values from historical data that are similar in setting and outcome, and consult with those who have content expertise. If these efforts prove unfruitful, a pilot study might provide rough estimates for some input parameters.
But an important caveat when using results from pilot studies is that the estimates come with a lot of uncertainty. They're based on small numbers, so treat them as guidance, not as definitive truth. Within reason, it's often better to build in a safety margin around those estimates and lean toward conservative values that yield a slightly larger sample size. In many cases, overestimating your sample is safer than risking an underpowered trial. The key takeaway? Do your homework to choose reasonable, evidence-based inputs and be transparent about your assumptions. Never back-calculate parameters just to match a desired sample size or fit within a funding limit.
Sometimes it isn't feasible to achieve a specific sample size for the ideal estimand. When that happens, be transparent and pivot smartly. First, choose robust analytic strategies. Consider Bayesian or frequentist approaches. Pre-specify sensitivity analyses such as inverse probability weighting, and report both intention to treat and per protocol estimates. Second, modify the design for efficiency. Stratify or adjust for key prognostic covariates. Add pre-planned adaptive features, or use efficient structures like factorial, crossover, or stepped wedge designs. Third, optimize outcomes and effect measures by selecting higher frequency endpoints or hierarchical composites to boost information yield. Fourth, interpret transparently and ethically. Emphasize effect estimates and confidence intervals. Justify wider non-inferiority or equivalence margins when appropriate, and clearly state limitations and context. Fifth, seek additional resources. Use power calculations to justify added funding or extended recruitment time.
We've covered a lot of ground, and we hope it is obvious that sample size planning isn't done in isolation or on autopilot. That said, there are many additional considerations for sample size planning beyond what was described today.
Exactly. For instance, we didn't cover more advanced topics like adaptive and group sequential designs, where interim looks at the data can trigger sample size re-estimation or early stopping for benefit, futility, or harm. Nor did we explore specialized trial structures such as stratified randomization, crossover trials, factorial designs, and stepped wedge designs, which require their own sample size frameworks. We also didn't touch on correcting for multiple testing, including how to adjust significance thresholds when testing co-primary outcomes or multiple endpoints. There are also additional considerations for variance inflation in hierarchical models, powering for subgroup or interaction effects, or simulation-based approaches for highly complex designs. These advanced methods build on the same principles we covered today, but require deeper statistical expertise and careful planning with an experienced biostatistician. Leave a comment if any of these topics are of interest.
Thank you for joining us. Bye for now.